Thank you. Hi, everybody. Come on in with your treats. Go easy on those carbs. I guess it's too late. I had my piece of chocolate cake. Okay, please take your seats. I think we're out of shamrocks. Yeah, there's one person that has to get their gift card.
That was fun.
It was fun.
It was really fun.
It wasn't my idea, it was Marianne O'Connor's. She's always creative.
Well, it was a great idea.
Yeah, we're going to do it next year, but the shamrocks are going to be a lot bigger, I think. They were hard to find.
I think you guys did a good job hiding. That's the real.
Do a better job hiding them?
No, I said you did a good job.
Yeah, they were hard. Okay, everybody sitting down, shutting doors. Excellent, thank you. Okay. Okay, everybody, it is my pleasure to introduce to you Dr. Angela McConnell. And she's a visionary executive, retired U.S. Air Force Army major, and the founder, president, and CEO of the Northern Virginia Veterans Association, with more than 35 years across military intelligence, healthcare strategy, and veteran advocacy. She is nationally recognized for building sustainable systems that close service gaps and improve outcomes for vulnerable veterans and military families. And you know, women are veterans, right? That's why we're covering this topic as well. Dr. McConnell is known for designing mission-driven strategy, advancing culturally competent healthcare, and leading multi-sector collaborations that drive measurable community-level impact. She also advises leaders on organizational change, value-based care, integrated service delivery. As owner of Q Integrative Healthcare, and you should Google that, it's amazing what they do, and host of Dr. Ange Mack, she champions the whole person, patient-centered care, and is currently focused on improving outcomes for women in midlife by addressing critical gaps in provider education, patient literacy, and coordinated support and treatment around perimenopause and post-menopause. A sought-after educator, media contributor, and thought leader, Dr. McConnell brings deep expertise, clarity, and a systems-level perspective to transforming how communities serve those most at risk, including our nation's veterans and women navigating potentially devastating midlife health challenges. And she does it with tremendous skill and compassion, respect and dignity for everyone. So without any further ado, let's give her a big hand of applause.
Good afternoon, everyone. I am so happy I got this hour, and I felt a little bit bad for Dr. Carolyn Baugh for getting that after lunch. I have the after coffee and sweets group, so really happy to be here. And again, my name is Angela McConnell. I have 22 years of military service, and I have about 30 years in the integrative whole person health field. And at the end of this presentation, we're going to play a video that really outlines the way you can get and receive services, what the Northern Virginia Health Foundation does for veterans, and how we support women and veterans in the military. But today, I wanted to talk about advancing women's health during perimenopause and menopause. And I want to thank Dana and the leadership here for recognizing the importance of this topic. So I'm kind of getting an idea. I'll probably stay up here because I can see you guys better, and I'm kind of short. So I think if I'm up here, I'll be able to see people and recognize their hands and their questions as we go forward. So again, Northern Virginia Veterans Association, been running that for 11 years now, founded it in 2015. And I've also been doing integrative healthcare for quite a while. I taught at George Washington for a while. I consulted, educated for many, many years, and I'm happy to be here to talk on this subject. The learning objectives, I can only use 3. You'll probably learn 30 just going through this today. Some of the slides break the 3 bullet point rule, and that's because I'm hoping after this you all can receive these slides and you can take them with you and use them in your workplace and beyond. But I want to ask, and this is going to be very, very engaging, back and forth. I'm going to be asking you all questions, and I want information from you all. And the first question I want to ask is, what is menopause? Do we all know the definition of menopause in this room? Can someone yell it out to me? Yes, you're all correct. and
When you stop menstruating for at least 1 full year.
yeah, so that is the medical definition. When you stop menstruating for at least 1 full year, then boom, you're in menopause, and the next day you're postmenopause. What happens the time prior to that? What's going on, in your body? Oh yeah, this is just a taste. It's not something old ladies get, which is what I thought. And when I was in my 40s, starting to have symptoms that I had no idea, even though I was in the healthcare field, and I had been doing whole person assessments and care, and I really felt I understood my body. I was also very athletic, very much into weightlifting and jogging and all the things, and I'm like, oh, I would know what was going on. You know, if there was something devastatingly wrong with my body, I would be able to figure it out. And in my 40s, I started having cardiovascular symptoms. And I'm like, all right, let me get the full workup, the whole stress test, the MRI, the nuclear medicine test, like everything. And they found it completely inconclusive. It's all in your head. Here's an antidepressant, go home and sleep. Take a glass of wine, just don't worry about it. And I wish I knew then what I do know now. And what I do know now, I'm going to share with you all, and you're going to understand probably more about me in the next hour than you ever wish you did. But I am very much an open book, and I do this because I want to educate, and I want to educate the women of our population and the healthcare providers that are trying to treat you and treat you well and accurately. But yes, there can be weight gain. Menopause average age now is 51 when you have that 1 year past. But up until that point, what's going on? What's going on with the estrogen in your body, the progesterone in your body, the testosterone? Did you know women have more testosterone in their body than estrogen? That's a fun fact. Most of you probably know a lot of the things I'm going to share today. The good part is I'm also going to share how you can take this knowledge, educate your patients, and educate the providers that you coordinate for them and with them. I think that's the most important piece that we're going to be able to take home with us. I've had women come to me and say, oh, I've never had a hot flash. They're 60 years old, 65, 70. I didn't have menopause. And I'm like, you went through menopause. You did go through menopause. But sometimes those symptoms aren't really obvious. Sometimes people sail through. Women just don't have a lot of issues. But I will say your estrogen has dropped. Your progesterone has dropped. Your testosterone has dropped. That's natural. It is normal. Every woman, if you live long enough, you're going to go through it. And that's perfectly fine. The not fine piece is that we do not have to suffer through all of this. We do not have to be dismissed at our doctor's offices. And we can get educated and also educate your doctors on what you want, what you need. I will say that this is the first time I've talked to this association about this topic. Previously, it was strictly military culture a few years back. I loved it, but when I was told I was going to come and talk to case managers again, or asked, I was more than thrilled because I think you guys are so central to patient health and everything you do. So again, very, very happy to be here. So osteoporosis, bone loss. At what age does most insurance authorize a woman to have a DEXA scan? 60. How many years past menopause is that, most likely? 9 or 10. We lose bone when we start to lose our hormones. Our estrogen, our progesterone, our testosterone, we begin to precipitously lose bone. When I was 57, I'd gone through menopause. They're like, let's do a DEXA. I'm not sure whatever, let's do a DEXA. I've exercised my whole life, eaten well, got that protein in, right? Everybody's big on the protein now. Did all the things, got a DEXA scan, I was like negative 2.5 in most all the bones they looked at. That's osteoporosis. That's not, you're getting there, there's a trend. It's like, you have this now, you're at risk of a fracture going forward in your life. And I was just dumbfounded. I'm like, there's no way. I'm healthy. How could I have osteoporosis? Nobody really had the answer. You're a woman and you're aging, that's what happens. And I'm like, no, that's not the answer. That's not the answer I want for me. That's not the answer I wanted for my mother, who also has it severely. And that's not the answer that I want any of us to have to deal with or accept going forward. So yes, menopause is natural. Whoops, I'm back. So now I want to do a poll. You guys don't have to participate if you don't want to, but I would like for you to raise your hand if you're a woman. Wow, look at that. How many women? Now keep your hand up for a second, and if you're a woman over 40, keep your hand up, if you don't mind. Okay, so my research was correct. You can put your hands down. The research that I did when I realized I was going to be talking to you fabulous ladies and gentlemen was that most of the people in case management are women between the ages of 41 and 55. And I'm like, perfect. I can make this presentation specifically about, in the beginning, how to help yourself. Because who often do we most overlook in our lives? Ourselves. Why? Why do we do that? It's culturally, it's how we were raised, it's what we feel like we need to do. But as you all know, if you don't take care of yourself, it's hard to take care of your patients, it's hard to manage your workload, hard to take care of your family. So I want to talk about in the beginning how we can better take care of ourselves, because you guys are the ones, in the field, in the weeds with these people. You're working with the patients, trying to do what's best for them, while you may have depleting energy. You may have brain fog. You may have so many health conditions and issues that could potentially be taken care of if you knew what to do for yourself. And again, we're not living this life to suffer. And I also will say, if you don't mind, this is the first time I presented to your group. If you see something that I could improve upon afterwards, come and let me know and say, hey, this was great, but you missed this really important component for case managers, and I think leadership would like to know, and I think case managers would like to know this for the next time. So having some of these issues yourselves, and I kind of got a good gauge of like 95% of you out there are women over the age of 40. So this could be or will be impacting you potentially, and just kind of recognizing it with yourself. Because when you understand, and I'm going to list so many health conditions and symptoms, you're going to see the symptoms, you're going to see the syndromes, but when you can understand what's going on with yourself, you can so much better understand what's going with your patients and other people in your life. This presentation is not for everyone. Not everyone's going to get something out of it. So if you're not a woman, or if you don't have a mother, or if you don't know any women in your life, or have friends that are women, or have a sister or an aunt, this may not pertain to you at all. And that is my very dry way of saying it impacts everyone. And we really need to get educated, because sadly our healthcare providers aren't educated like they need to be. So here you guys are with me on the forefront getting this information. Half the 8 billion people in the world are women. That's a lot of us. That's a lot of us out there. But do you know that we are most under-researched? They're just typically across the board with regards to, do I pick a male mouse or a female mouse? Females are more complicated. Let's go with the male version to study. In mouse form, in clinical form, across the board, we're studying males because they're easier. Why? Males don't make babies. So we, wonderful women, are designed to create human beings within us, yet we're not being studied and researched and treated and cared for appropriately, in my personal professional opinion, and that needs to change. And we are making movements at the federal and at the state level here in Virginia. I am actually part of a lot of these movements and initiatives to help women get more research, but more importantly, just educate the doctors. Educate the healthcare providers. At least let them know so they can tell something to their patients and clients that come through. So yeah, I quickly did some research in the last year in PubMed, and I looked for females in research that were studied specifically. 120,000 studies on pregnancy or something that has to do with pregnancy. Great, wonderful. This is what we need. We need to be able to study, make sure we have healthy moms and healthy babies. But then I looked at what the other studies were. 10,000, 4% were on menopause and perimenopause symptoms. Over half the people in the world are women. They say 1.5 billion are potentially going through perimenopause and menopause. I think that's lowballing it. I think it's a lot more billion than 1.5, but still, why? I keep going back to the question for myself is why? Why are we studied so little? And why haven't women stepped up to really make the point of getting more of this done? And that's what we're here doing today, together. In older women, and this is specifically older women, if I take women 20 years later or 20 years earlier, these will change with regards to the leading causes of death. Cardiovascular disease, you guys probably know that, right? The #1 cause of death in women, cardiovascular disease in older women. Why? Why in older women? Yeah, well, there's lots of reasons that I've read and I've researched, but what I do know is that there are estrogen receptors on every single organ system in the body. In your brain, in your heart, in your GI system, your skin. Every single organ system in your body has estrogen receptors. And when those receptors dry up, because you don't have estrogen anymore, those downstream pathways dry up. And people wonder, well, why am I not thinking well? Why do I have brain fog? Why is my brain not working? Well, those estrogen receptors are not being filled anymore, so you can think and act and do things as quickly as you were doing. It's not in your head. It's not necessarily because you've been overworked or you're over-fatigued. You are literally losing hormones that your body was used to having forever. I like to call it the reverse of puberty. So instead of getting all the hormones coming into your body, you're losing them all, and usually right around age 40. Now, some people can lose them earlier, right? You can have oophorectomy, where your ovaries are removed and you don't have the hormones anymore. And some women can go through early pre-menopause due to other health conditions, but generally right around 40. And now you can see the other leading causes of death. Cancer, again, why at this age? It's not just a sign of old age. And that's in the research. Respiratory diseases, unintentional injuries, accidents, falls. Why are we falling more when we get older? Oh, yeah, our bones aren't as strong, our muscles aren't as strong. You know, say again? Yeah, vision, your eyes get worse going forward. And again, there are estrogen receptors in your eyes. I started losing vision about 3-4 years ago when I didn't know what was going on. And I'm going to share this story, but I was like, why are my eyes drying up? Why is literally every area in my body drying up? I mean, every area, ladies. So, yeah, it was not fun, but it can be fixed, a lot of it. So, syndromes of menopause. Who knew there were so many syndromes associated with menopause? This is just getting out there. Why has this been hidden? I just don't get it. Again, I've been in the healthcare field. You guys have been in the healthcare field. How many of you have seen all of these syndromes of menopause and anything in your education? A couple. Why isn't this out there pervasively to talk about half the women who live on this earth? I don't know. But I do know there's 7 here listed. The metabolic syndrome of menopause is the one that specifically we're going to get into a little bit more today because it's kind of almost a catch-all. vasomotor symptoms, which is basically having these hot flashes, but it's a lot more than that. It's your system misfiring information to your brain, which is making your vasoconstriction happen and not happen and have hot flashes. I noticed they kept the room very cold in here today, so hopefully that was helpful. Neurocognitive syndromes, I had every one of these things: cardiometabolic, osteometabolic, genitourinary syndrome, incontinence, issues that you have, even if you haven't been pregnant, start to come about, and you're like, why am I all of a sudden standing up and starting to walk and starting to pee at the same time? Doesn't make sense, nothing has changed, I'm just getting a little bit older. Why are those muscles? It's because there are estrogen receptors in even our lady parts, a lot in our lady parts actually, that go away, and we don't have the ability to contract. It was last year, finally someone said, go see a pelvic therapist. I'm like, why wasn't I given a pelvic therapist after my children? I'm like, that should just be a normal course of action. Again, things that have just been grossly overlooked. Someone had mentioned eyes, and with that, sleep issues come about, mood, inflammation goes crazy. Your immune system, if you didn't have an immune condition prior to menopause, hopefully you won't get one, but that's when they start to really pop up and get exacerbated. So the metabolic syndrome of menopause, it's a period of heightened cardiometabolic vulnerability due to decline in estrogen, most likely. This is a correlation, this is not a causation. We are still trying to get the research out there, but I tell you what, when I got sick about 3 or 4 years ago, I started doing the research, and I looked at all of the issues that could happen due to a decline in estrogen or progesterone or testosterone. And for every specialist I saw, I now have a whole pile of current research and some older research that pertains on why this impacts my heart, why this impacts my vascular system, why that is impacting my brain. And I'm going back to all these specialists that they sent me to, when all they could have really sent me to as a very well-educated case manager, and they would have said, maybe we should look at your hormones. Maybe we should do a full workup panel on you. How old are you? Oh, you're 50? Okay, let's do a DEXA scan. You probably should have had one 10 years ago, really, if you want to catch things early. So, I love that you guys are doing the things that you do, and I think you can probably make the most difference out of any one specialty, because they send you around. When they don't know what's going on with you, they send you to one specialist, and then to another specialist, and then, I don't know what's going on with her, send her to another one. It's such a fun process, isn't it? Just all the time and money and energy. So body composition changes. What else happens when you start to go into perimenopause and your hormones? Any body composition issues? Can't sleep. Weight gain, possibly? Yeah, you get hot. Feel like you're running a fever all the time. Sometimes the weight gain, they call it minnow belly. That's pleasant. It's like aging vagina. That was a thing too. I'm like, really? That's a diagnosis? My goodness. So metabolic syndrome. It's true. In history, that was a diagnosis. I have like all the terms of how they've changed over the years. I'm like, that's not right. Yeah, it is a sad state of affairs. So a metabolic syndrome, I like to call this the pre's. This is what I did my dissertation on, metabolic syndrome, because it's the pre's. It's pre-diabetic, pre-cardiovascular disease, pre-fatty liver, like all of the pre's. We want to get people before they get into the full-blown metabolic syndrome and cardiovascular disease and fatty liver disease. And what do you all see, and what can you recognize in your practices and your work are some of these things as they start to creep up? It's like, oh, you've had high blood pressure the last 3 times you're in there. You can only blame that on white coat syndrome so much until you start to recognize trends. And I know everybody is working really hard with their patient populations. We're trying to do the best we can and take care of them. But it'll be really, I think, enlightening and helpful for you when you start to see some of these things and say, oh, maybe there's something else going on here. We checked the thyroid, that's good. Maybe we can look at some hormones and some other things. And those are the kind of conversations and educations and presentations I give to healthcare providers in the clinical and the hospital setting. This one is geared toward case manager, but there are ones specifically for healthcare providers. because they don't know what to ask their patients. And if they do ask, or they ask for labs, they don't know how to interpret the labs. Then they don't know the proper types of treatments that are out there. And there's so much education and information, but our healthcare providers are not being trained unless they're going to look for, or unless they're in the leading edge hospital system where they are training their providers. And if you know one, let me know, because I've yet to find one. There are some fabulous education programs out there, but to have a whole system, a hospital system, there are very few. Another fun fact with high cholesterol, and this is something I learned too a couple years ago. So what are the precursors to estrogen and testosterone if you're looking at the kind of the metabolic pathway? Does anyone know? Cholesterol. So cholesterol makes estrogen and testosterone. And when your body starts to lose those, what does it try to do? Create more cholesterol naturally, because it's trying to fill that, right? So you go in and you've been doing the same thing and eating the same thing for years, and all of a sudden your cholesterol's going up, and they're like, oh, you need to get on a statin. And you're like, well, wait a minute. Cholesterol has a really important function in my body. I want to know why it's increasing. And it's increasing because those hormones are going down. And it's just trying to take care of you, because it is a very important, hormone, cholesterol is. It is a hormone, right? I think. Don't quote me on that. So cholesterol, I found out for myself, and now for others, is the precursor of the estrogen and testosterone. And when I started on my estrogen and my hormone replacement therapy, my cholesterol magically went down, and so did a lot of other things. So case managers, you guys assess all these things, right? You're looking at these things going on potentially in your patients. You see them in your records, yes or no? Yes, for the most part. You have access to these, and you know if someone has high blood pressure. Are you still asking about sleep? Is that still on the intake? You want to know about their sleep. So important, so important. Cognitive function. And I love some of the talks on capacity and cognitive function. It's like, wow, the delirium and ask me what day it is, like all of these things that I really had a hard time answering when I was kind of in the deepest part of my menopause, my perimenopause, all of those things I could relate to. So knowing the difference, and you guys have a hard job, but an extremely important job, right? Because you have to discern, does this person have the capacity to make these decisions? Or are they just having a bad day? Are they like right there, perimenopausal, and their hormones are going sideways and up and down, and they just can't think right, and this will pass potentially with treatment. Lots of things case managers can do. And the most important thing I think you can do is catch it early. So what I want to ask you all is, this is kind of a challenging question, I think, but if you found a patient that you thought, oh, this woman, she's like 45, she might be right in there, she's not sleeping well, she's having brain fog, she's having heart palpitations, who can I refer them to? What would you do at this point? GYN, possibly, that makes sense, right? GYN, they're sex hormones, a lot of times. Functional medicine, love that answer. They really do great panels, and they can look at things across the board. Functional medicine, someone boarded in integrative medicine, potentially, also trained. But the thing is, you still have to make sure they're trained in how to treat women going through perimenopause and menopause. So very, very important. This is our challenge. It's like, oh yeah, I may know exactly what's probably going on with this woman, but now who do I refer them to? And there are some really great insurance reimbursed programs like MidiHealth, MIDI, and other ones that work well with women if they don't have doctors. My job is to work with the patients and work with their doctors, so I can also educate the doctors, hopefully not offend them, because no doctors want to know that they don't know something, especially if it's in their field of gynecology or endocrinology. That's kind of the sticky point, is like, how do we educate so you can have the informed consent, right? I've had many doctors say, I'm not gonna treat, I just won't. And I ask, well, what are you scared of? And they're afraid of being sued. I'm like, well, what if the patient sues you when they come back and have osteoporosis and, mixed connective tissue disorder, and, what if they come back and said this could have been prevented? Where's the liability then? And I don't really get good answers because at that time they were pissed at me. So, but the point is I try to educate the doctors because we can go and get good care. There is good care, and you can send your patients, if you don't have any luck working with physicians, there is care out there, but I really want to work with you all to work with your physicians so they understand how to help, right? Get a lot more, kind of more of a exponential impact, I think, when we do it that way. So you all so there's a couple that said they had some training in perimenopause and menopause. Anyone have training around the treatments? Like what kind of treatments are out there, the guidelines? Do you guys know what happened last year with the FDA and hormone treatment therapy? Yes, they got rid of the black box warning on hormone therapy. That should have never been there to begin with because it started with the Women's Health Initiative study. Anybody familiar with the Women's Health Initiative study? About 20 years ago, a few of you. So there was this great study because physicians were seeing fabulous results from their women patients who got on hormone therapy. And so they're like, let's put, billions of dollars into the study with the NIH. And I think it was 1990, they did a study. And they had a group of women that were on, it's called a conjugated equine estrogen, which is what they used back then. And women that had a uterus also they were on a progestin. And that was one cohort, that was one research cohort. And so these women took the estrogen and the progesterone that was given at the time. And the women that didn't have ovaries and a uterus, they just got the conjugated equine estrogen. So that was the other study. And what they found was at some point, women started having a higher rate of breast cancer a few years down the road, because this was a very long study. And they immediately stopped the program and they singled out a cohort of women and they said, we have to stop this because it causes breast cancer. Nothing was peer reviewed. Nothing went through the formal channels. The media got a hold of it. All of a sudden it was in the newspapers, it was on Time magazine, it was out there that hormone therapy causes breast cancer. And we have been scared ever since. The women were scared, their physicians were scared, and we've lost 2 generations of women, my mom being one of them, who never had the opportunity or the choice of being on hormone replacement therapy. I'm not saying it's for everyone, but I think everyone should be educated. And if it's not for you, I have friends and clients that I work with that are not on hormones, and we look at all the other lifestyle changes that we could do that we should be trying to do anyway. The nutrition, enough protein, enough hydration, doing those nutritional blood panels and urine panels so we know what we're deficient in and we can supplement the right things and not try every supplement under the sun hoping to feel better. So there are ways to go about this, and the Women's Health Initiative study was good in some respects. I'm not downing the whole study, but it was misinformation that was put out there. And the other interesting fact is the women that didn't have ovaries and they didn't have a uterus to protect, they were only getting the estrogen. Those women, in that cohort of women, they had cardiovascular protective benefits, they had bone protective benefits, they had neurofunctioning benefits. None of this was ever out there. And the research is still there, and I still refer to that because that's like, these were the benefits that were never put out there. And some of the research is coming around, we're getting more and more, and we're getting better research, but we're never gonna have, I don't think, a study this large with this many billions of dollars put into it, because nobody wants to pay for that yet. Not yet. We're working on it. We hope. So we want to eliminate multiple unnecessary specialists, referrals, and patients getting overwhelmed and frustrated and scared by asking questions like, how old are you? Are you still having a period? Let's normalize the conversation around perimenopause and menopause. Let's just normalize it. Just go into work and start talking about it in the break room. I do it in the grocery store. I'll just randomly standing in line, ask my poor husband. He's like, again, relevance to case management practices, relevance to you guys. You can support your patients better. I would like to see perimenopause or menopause-specific case managers. You all can go to the Menopause Society, get trained in this specifically. Look online. I have lots of informational YouTubes and such. And I can give you the names of people like Dr. Vonda Wright, who is an osteopathic surgeon and also a menopause, perimenopause expert. She does great videos. Heather Hirsch is a physician who has her own academy that trains physicians and healthcare providers. There are some great resources out there for us. We just have to get to them and use them, right? Person-centered care, that's kind of what case management is. So in my work, integrative medicine, which I've been doing for 30 years, whole person health, you look at everything. You look at not just their health conditions, you're looking at their demographics, right? Are they low income? Are they people of color? How could they be, are they being underserved? Are they being stigmatized? Do they have other issues? I mean, we're looking at the whole person, mind, body, spirit, their emotions, their psychology. So again, you guys are the perfect group. This is gonna get personal. This is when you learn way too much about me that you never wanted to know, and now you will, and you won't be able to erase it. But 3 years ago, I was diagnosed with ALS, Lou Gehrig's disease. I was told I had about 5 years to live, to get my affairs in order. I was getting ready to get married. There was a lot of great things going on in my life, and I started having severe symptoms. I started having uncontrollable muscle spasms, high blood pressure, like 200 over 100. I went to many specialists over that year in that course of action. I asked for a referral to UVA Medical Systems because I was being seen at the VA at the time, and I will get into some VA-specific resources, and the VA is not all bad. They're very wonderful in areas, but they're lacking in others, and I could probably say that about many healthcare systems, but because I'm a veteran and a woman veteran, I can talk good and bad about that. So, cardiac palpitations, I mentioned that earlier, started in my 40s. Had no idea it was related to probably a loss of progesterone. Dehydration, even though I was drinking all the time, very dizzy. My teeth, I was having teeth issues. I had to have extractions. I was having root problems, like just all of a sudden. And I've gone back and done research and looking specifically with regards to teeth and dental. And yes, because the loss of hormones, you have the loss of muscle and tendon receptivity in your teeth and your gums and your roots, and they can start to fall out. And not even decay. There was no decay there. It was just sore. It was not infected, the one tooth that I had to have extracted. But these kind of things kind of continued on, and I was baffled. It's like, why at the age of 53 was I all of a sudden having all of these issues? And I talked to my providers that I saw, and I was like, I'm right there, I'm missing my periods. Could this have anything to do with like perimenopause, coming into menopause? No, men and lady providers. No, it would have very little, if any, impact. They were very wrong, very wrong. So these are some of my symptoms that I had personally, that I suffered with. I'm about 80% better, not 100%, but I'm about 80% better. Got a lot of things figured out. Had muscle loss and bone loss, as you know. Muscle loss for someone who's lifted weights their whole life is something very apparent. If you have patients and clients that come in, it may be hard to tell, what exactly is not normal for them. If they never had a lot of muscle to begin with, and now they're getting weaker, there's like a grip strength test. I know that is something that we can do, to measure that kind of strength going forward. There's basic, I know, exercises and things that you all can do to kind of measure their ability to balance and to walk or to lift something. But if you don't have a baseline, these things are hard to tell. And many providers, even ones that do understand menopause and treating perimenopause, they'll say, well, I only treat the symptoms. And I understand why they're saying that. They want to get rid of the insomnia and the hot flashes. They want to get your energy back and your brain working and all of those great things, but not one of my symptoms was related to my osteoporosis. I probably started losing bone 10 years ago. Had no idea. There's no outward symptom for that. There's probably not a big outward symptom for losing muscle. unless you're a weightlifter and you look and you're like, why can I not lift 20 pounds anymore? What's going on with my muscles? Why can I walk down my stairs without pain? So, I mean, a lot of these things, when they say they only treat the symptoms, I'm like, great, let's get that going, and then we'll worry about the other stuff later. But yeah, we want to look at all these things. I had the weirdest rashes and outbreaks. I had the high blood pressure, and they're like, here, get on this blood pressure medicine. It would cause delusions. Get on this one and cause weird outbreaks. Like, all of these weird things going on, because I probably shouldn't have been, I should have been on the medication because my blood pressure was high, but there was other things. What was causing the blood pressure to increase? Well, estrogen, it's a vasodilator. It will help your vessels dilate and your blood pressure go down and normalize. These are the things I never knew that I wish I did a couple years ago. And so what did I have to do? I went to integrative medicine doctor, who's my primary care now outside the VA, cardiovascular doctor, vascular specialist, neurological specialist, orthopedics, pulmonologist, ophthalmologist, physical therapist, chiropractor, acupuncturist, myofascial therapist, psychological, trauma, pain medicine psychologist, because when you have a lot of pain and you can't get up and do the dishes, it wreaks havoc on your psyche when you're used to being able to do all of these things and having the energy and the physical capacity. I was going through a lot 3 years ago. Urologist, urogynecologist, which I didn't even know that was a specialty until recently, a nephrologist, gynecologist, rheumatologist, gastro, allergist, endocrinologist. And it's interesting, again, not one of them said your menopause or your depleting hormones could have impacted all of these conditions. And what I found out after getting on hormone therapy, because I asked for it, I finally told the VA I wanted to find a doctor outside the VA who could prescribe hormone therapy. They found one. I got on estrogen, very low dose at first, was on that for about a month, and then I got on my progesterone. That did wonders. A few months later, I got on a little testosterone. World of difference. I could think, I could add again. I was having a hard time doing basic math. And not being able to write, 10-page budget grants, right? There's like all the things that I couldn't do anymore. I had to stop working for George Washington University, where I taught part-time. I had to stop consulting. I pretty much had to stop running Nova Veterans for about a year when I was going through all this. And thank goodness for my fabulous team that I had, board of directors, because they truly carried me. But I had to direct my life. I had to do the research myself. And then I got to a point where I was helping every girlfriend that I knew and saying, and they would come to me and it's like, this is going on, I'm having a hard time sleeping, and I'm having a hard time with my mood, and why do I have no libido anymore? And I'm like, well, probably because you're getting low in these hormones. And then they're like, what can I do? It's like, well, first you can go to your doctor and ask him to run these labs. And if you're post-menopause, there should not be any issue running labs. I've had doctors say, well, we know it's going to be low. It's like, yeah, we know it's going to be low, but we want to know how low, and then we want to know if the medication's working or not. Because if it's not, maybe there's something else going on other than just low sex hormones. And if you're still having periods, they don't want to do it because they're like, it'll change from week to week. Your hormones will be up and they'll be down. And I'm like, yeah, but you can kind of get a baseline. And if they're super low, especially I know a lot of ladies will get on progesterone in their 40s because of some of the symptoms that will sometimes take care of some things. But if you get ahead of it, then at least you'll know where you are going forward. If you wait till you're post-menopause, the benefits aren't as great, and they say you kind of want to be able to get on hormone therapy for the greatest benefits within that 10-year window past menopause. And there's even further research that says there's no reason to ever go off of it. I talked recently to an over 50 retirement community, 4 Seasons, to a group of wonderful ladies. They all knew what a DEXA scan was. They all had one, which is very different than a younger crowd. I can say, have you all had a DEXA scan? Do you know what? Had no idea what a DEXA scan is. So yeah, right, a different population. They're 60 plus, most of them. So they had a DEXA scan, but they didn't realize that their symptoms of osteoporosis and incontinence and insomnia might be able to be improved with vaginal estrogen, with potential transdermal, like a patch or a gel of estrogen, progesterone at night. I mean, just because you're older doesn't mean that these things may not help, and I think that's another myth. As it's becoming trendy to understand the perimenopause, menopause situation. Probably if you're on any kind of medical YouTubes, or I'm a constant consumer of information, there's always people out there saying you shouldn't go past a certain age and take this, and it could be contraindicated. There are very few women that will have contraindications. Breast cancer might be one of them. Stroke, previous stroke, aneurysms could be others, but very few women have contraindications, especially to vaginal estrogen, and that will help in a lot of areas with regards to incontinence and libido and getting blood flow, because when everything dried up from my eyes to my toes, all the parts were affected. And vaginal estrogen, I think, should also be prescribed to almost every woman in assisted living, skilled nursing, because what's a huge cause of kidney infection? UTIs. I tell you, I have not had a one. And I used to have them frequently, especially after sex. I would get the UTIs, not a one, since being on vaginal estrogen, since menopause. So, good stuff. It's all good stuff. Normally, it's all good stuff. So quickly, I want to talk about women veterans. I don't know, am I still good? I have about 5 minutes maybe. Women veterans, say again? Okay, good. Take me off the stage here in a minute, because I can talk all day on like each one of these slides. I am a woman veteran. We do studies on women veterans, and I will say that women veterans are the highest growing rate of the veteran population, so more and more women are joining the service. One of the issues with medical care is a lot of doctors haven't been trained to specifically work with women. That was one of the issues that I dealt with when I was in the 80s and 90s, is I would go to the doctor with a particular symptom, and they were usually trained to treat men, because that was the greater population. Many were very uncomfortable, even the GYNs talking about certain issues, whatever that may be. And I still find that today, and I find that today for me when I go to the VA, and their main patient population on average is a 65-year-old man. So how would they know how to work with me and my bone density issues when they're just used to working with mainly older men? And that's a reality, and it's unfortunate, but they're getting better. The VA is getting better. There's a brand new VA health center in Fredericksburg, Virginia, with a brand new women's center as part of that. I hear they're doing really great things. So they're trying to make the policies and make these changes, but they're still not training their healthcare providers enough, in my perspective, in my experience. So overall female population, higher rate of suicide between the ages of 45 and 55. That's just the female population. I'm not talking about veteran on this bullet. This is female population. Why do you think there's a higher rate of suicide between the ages of 45 and 55? What's going on during that time?
Confidence goes down.
What's that?
Sometimes they're doing
Confidence goes down?
Some people retire as early as 50 to 55. Lack of purpose.
Retire, lack of purpose.
About themselves because their body is not doing what it's supposed to do.
Yeah, you can get so frustrated with yourself. I mean, that is huge. As you're used to going at a certain speed, you're used to thinking in a certain way and performing. We are losing great women in industry and in the fields because they get to this point in their life, they don't know what's going on, and they quit because they just can't perform like they used to. Yeah, we can't have that. We're a huge asset. We have learned so much. We know so much. We are experts in our fields. We do not need to be quitting unless we want to be, for reasons of travel and fun stuff, not because of these reasons. Also, the divorce rate between this age group goes way up.
Libido goes down, weight is changing.
Yeah, libido goes down, weight is changing, lots of different things. You may not like your husband anymore, maybe you never did. HRT is not necessarily husband replacement therapy, as some of you may be led to believe. It's hormone replacement therapy. Sometimes you might need to replace your husband. Maybe you just haven't had the confidence or will, or sometimes maybe you just have to get your hormones back in balance, find yourself again, and get your marriage back. I will say that I've talked to many women's group, and I'm finally on some panels and presentation schedules to talk to men's group. And that's going to be an interesting conversation, because I had a handful of men that will pop up into some of my courses that I teach, and they'll start asking about their wives. And or like maybe their mothers too. When I was asking about the mothers, like, this is going on, what do? I want to be supportive, I love my wife, I want to help her. I don't know how to help her, but I know she's going through stuff. Sometimes we don't know what we're going through. So how on earth are we going to talk with our husbands about what we're going through? So we just need to keep educating. So if you have a woman that you're working with, yeah, bring in their husband. You know, just have the conversations. Now that you know these things, you can educate and you can refer to this. And I have all kinds of research, and if you need to know more, I have my cards on the table there. Just grab a card and email me. But I got to a point after everything I went through, and I was helping all my girlfriends, to where one of them said, I think you really should just start doing this. You really should just start educating and consulting, because you've done the research. You've done all of these things. You're helping every woman you come in contact with. Why don't you help more? And that's why a year ago I shifted my Q-Integrative, which is kind of the umbrella company, to the Dr. Ange Mack, where I'm specifically focused on women in midlife, because we just don't have enough support out there. I was like, I know too much. I can't go back. I'm still doing Nova Veterans. I'm still CEO, but I just hired a new executive director, and she's going to be doing all the day-to-day, so I'll have more time to focus on women in midlife and to continue educating with you all. 40% of worsening pre-existing condition, if you had asthma, if you had lupus or an autoimmune condition, if you had things prior to 40s and 50s and 60s, they may get worse. So if they do get worse, and this could be a question that you ask your patients and yourself, it's like, okay, this never really bothered me. I knew I had it under control, I had things in balance, but now, you know, I can't go out in the sun anymore. I have a bad, lupus rash, or, whatever the condition may be, it has worsened. Again, potential cause from low estrogen and other hormones. This is a handout that you all have, and you all have the copy that doesn't have the resources on the back. It's my fault because I didn't get it to the leadership in time, but they do have the one with, I believe there's 40 resources on there for you, for women veterans. And women veterans have a higher suicidality rate. They think more about suicide, and the rate is higher in women than men veterans. And I want to say it's the opposite with the actual follow through. Actually, committing suicide is higher in men because usually they have more lethal means to do so. Women can think about it. Many times they'll take a lot of pills, and they will try to overdose, or they're just tortured for years and years, and they're depressed, and they're angry, and they're anxious, and they don't feel like they have any help. I would say women veterans are potentially more impacted than civilian women, mainly because of some of the things they've been exposed to in the military. So as a woman veteran, I can say that at the age of 18, I was put in combat boots and rucksack on my back, and you were running, down the road and doing these marches and doing a lot of trauma, on your young body, which can impact you down the road. As a woman veteran, you are potentially deployed to places like Iran and Iraq, and you're around things that could have many, many environmental exposure risks, like burn pits. So these are the things that kind of the overall rates and reasons and issues associated with perimenopause affect women. We're finding that it impacts veteran women more because of all of the things they have gone through within the military. This is what I trained the last time I came and spoke to you all, and I don't know if there's anyone here, there's a few people here that got my military culture and healthcare resources course that I gave to you a few years back. I don't even remember what year, Dana, that was, but it was a few years back, before I got sick and got better, that's for sure. But this little flow chart was very, very similar to the one that I used. And you can use this for any veteran. And one of the number one things we need to ask our patients to come in to know if they're a veteran is just ask them if they ever served. Have you ever served in the military, in the reserves, in the National Guard? And the reason those words are important is because many veterans that maybe served a few years don't recognize themselves as a veteran. They're like, I only served 5 years, I'm not a veteran. I was never deployed, I'm not a veteran. And no, that's not the case. You're still a veteran. If you served 1 year, you're still a veteran. So we always want to ask, have you ever served on your patient intake? Those are the things. And then you kind of want to follow the flow. You want to know where they served. And yes, these are a lot of questions, but if you really want to understand what this veteran could have been exposed to, these are the questions that we need to ask. And in my other class that I give, I have like little intake handouts, and there's a military sexual trauma piece and questionnaire, depression piece and questionnaire that's specific to military women and military men. So ask where they served and potentially determine if they were exposed to anything. And I come back to the audience and say, if you ever have a question regarding the veteran you may be talking with or helping, supporting in some way, refer them back to the Northern Virginia Veterans Association or call us and talk to us, and we can point you in the wrong direction. Let's hope not. Point you in the right direction. And because I was going to say the VA, and hopefully that wasn't like a strange subconscious mix-up there. No, point you in the right direction, either with the VA, the Virginia Department of Veteran Services, or with us, depending on what the need might be, because there are hundreds of resources for veterans. Many people don't know the first place to start. So I would say call us or call the Department of Veteran Services, Family Services. They also have a wealth of information, and we will get you in the right direction with your veteran. There's also a lot of information on the websites too. We want to know if the veteran's registered with the VA, because that's helpful. If we know they're registered, many veterans don't want to be registered with the VA, which is fine. A lot of veterans that we help and support aren't registered, and they don't care to be. So we work with government agencies, other government agencies, local ones, state ones. We work with Social Security. It just depends on the veteran and what they need. Again, with the Northern Virginia Veterans Association, we do a holistic approach, so we can get a really good idea of what they might need. Perform a complete menopause intake. I can provide that to you. If you need one, if you'd like one, I can provide you one that's been created specifically for veteran women and then just women in general. And then have your ladies get a DEXA scan. If you can have them get their DEXA scan early, and I'm not saying I want them on bone protective medications like bisphosphonates early. Those have been shown not to be that great later in life anyway. But you can't say, let's get you on a program to reverse osteoporosis. 10 months after my diagnosis, I reversed my osteoporosis. Once I learned I had it, I learned what I needed to do for myself, and it did not include medications other than the hormone therapies that I was on, and eating right and doing some other exercises. It can be reversed, which I didn't know either. I thought it was like a death sentence, like I'm gonna break my hip and die a year later, but I don't think that's gonna happen. Provide appropriate treatment and care. That's what we try to do, right? And where do we send our patients if we don't know who to send them to? Again, talk with your department leads. Ask these questions. Be proponents in your field. And I know I'm running out of time here. I got the 10-minute card. But I will say that you all are the leaders within the case management industry, and that you can make this perimenopause, menopause component of your work paramount. Again, you're 40 years old, you start going through this. How many years of life do you probably have left to live? Maybe half? Maybe you're only halfway there, right? You got another good 40 years. Why do you want to live it having osteoporosis, brain fog, cardiovascular disease, potential cancers, when you could possibly prevent a lot of these going on and have a much healthier, longer lifespan? These are the 6 primary areas that I did some research on prior to developing this presentation for you guys. And it basically just says, find a way to bring it into your practice. Is there anyone here that incorporates anything around the perimenopause, menopause space yet? No, see, not anybody. This is half of our woman population. We need to be doing these things. And if you don't know how to bring it up, if you need a paragraph to send your boss, or some research stats that'll get them to kind of sit up and take notice, especially if it impacts their bottom line, then let me know, because that's what we do, because we're trying to convince people it's the right thing to do to take care of us women. Why people would need to be convinced of that, I don't know, but it seems to be what we have to do. So with that, I want to thank you all for your attention. I believe they're going to do a short video on the veteran aspect, and I'm sorry if I didn't cover all the ways to traverse VA benefits, because I wanted you to stay awake and learn something else. But if you do have questions, you can reach out to Nova Veterans at any time, and we will help you with those things. Thank you. And if it doesn't work, that's okay.
No, I'll make it work.
She's got to make it work.
I can't help you, so let me get into it.
Let me just ask. I didn't do a question and answer. I felt like I was asking you all the questions. Anybody have any questions while we're trying to get this up? Yes.
I have a comment. It's interesting because we're just now becoming aware of ADHD in women and menopause and how those two things are affected.
Mhm.
Because women's hormones are more protective than like if you're a male at birth.
Right.
And so what's interesting is they're finding as their hormones go down, we don't have that natural protection that helps with ADHD.
Very true. I have heard that as well. Yep. Some of
And that
those.
also affects the cognitive impairment. It can also affect your overall functioning level. It can affect your ability to regulate moods and emotions.
Yes.
It also affects all those things.
So in addition to autoimmune conditions being exacerbated, ADHD and other pre-existing conditions, very true. Yes.
Yes, I was wondering, I heard you talk a lot about HRT therapy, and I was wondering what you thought about bioidenticals.
Well, I should have probably clarified that in the beginning. When I was talking about hormone replacement therapy, I was specifically talking about bioidentical hormone replacement therapy, and there is a difference. Birth control pills, they're not bioidentical therapy, and we've been using those forever without anybody pushing back saying, oh, don't take those, it's going to cause, a heart problem or a cancer. And they are the synthetic version, they are not the bioidentical version that we've been using for decades. And the bioidentical hormone replacement therapy is more aligned with how we create and receive these hormones anyway, and they're considered to be more safe, and research and science has shown them to be more safe. So yeah, thanks for bringing that up. I didn't clarify that in the beginning. That's in my physician speak, but thank you. Yes.
Hi. So, when I went through menopause, they told me I was only be on hormone replacement therapy for 5 years. Is that now debunked?
That's interesting. My former GYN, the one I fired, told me the same thing. Because, I started getting improvements in my bone health and just everything across the board. She's like, well, you're going to have to go off it in 2 years. And I'm like, what? Why? There are no guidelines that say you have to be off it in 5 years. There's nothing out there in the research that says that. I would say try to get them the research or the information, the new guidelines, and if you can't, find another physician if you want to continue staying on it. I've had women their doctors have just stopped them cold turkey after 5 years, and they just plummet with regards to their negative symptoms, and they're not sleeping at night, and they feel sick, and they feel moody, and like all of the things that started to get them to feel better when they were on it. So yeah, there's not a 5-year rule out there. Yes?
Are there any, I see so many posts on social media, Instagram, Facebook, etc., from different doctors that are really coming to the forefront of all of this perimenopause,
great.
menopause, but it's hard to distinguish who is credible and who is not. Are there any people or books that you recommend or resources that you could give us, people to follow?
Yes, I can. In fact, my very first YouTube video since I started doing this work was how to identify someone who is actually an expert in this field, because there are so many influencers out there talking a good game without any experience or education or research to back them up. But I will give you some names, and I've also read some really great books too. I can give those to you. But Heather Hirsch, Hirsch, is fabulous. Kelly Casperson with a C. They're on YouTube and they're on Instagram. They have a lot of great training. And Dr. Vonda with a V, Vonda Wright, W-R-G-H-T. I heard all three of them speak at the women's conference in Orlando last year, and they were incredible. I heard a lot of others. I look at the researchers. Lisa Mosconi is a neurological researcher. She has some fabulous stuff on the brain and what we go through. Debbie?
Yep, I'm ready to go. And Dr. McConnell, if you don't mind staying afterwards,
Not at
if there are
all.
more questions, but we'll play the video and then we're going to wrap up for the day. But
Yeah.
if you don't mind staying, we'd love to have
I
you.
will be here, so if you have any questions, please find me. Okay, we'll talk after. Thank you all.
In the service, the Northern Virginia Veterans Association provides personal direct support around multiple and diverse services and resources.
I started out looking for some transportation for a sergeant major friend of mine who was 83 years old.
My husband had become disabled and blind.
I've been using the program for about 2 years, and it has helped me immensely.
A great benefit for people that need it, and we encourage people to try to use it.
Our mission is to provide access to needed services and diminish the inequities our most vulnerable veterans struggle with and experience every day.
The other resources was our home, being able to stay in our home, and you connected me with many benefits and resources. Without that, I didn't know where to go.
Well, they develop a sense of security, and so it is truly a blessing, your organization and all that it does. Thank you very much, Nova Vets.
Please help us support, protect, and honor our local veterans by visiting us at novavets.org.